Welcome all of you. Can I request everyone to have their cameras on so that we know how many of us are there? Good evening, ma'am. How are you? Your device is on mute mode.
Oh,
Yeah,
I'm fine. How are you?
I'm good. Thank you so much. How are you, Dr. Atul?
Good evening.
Very good evening.
Yeah.
How are you? So we are just five of us. Dr. Varsha is there, but she's driving. So I think maybe by the time she reaches home, then she'll have her camera on. But
Okay.
we don't have other participants. So what do you suggest? Should we go ahead with the discussion or wait for 5 minutes? Whatever everybody says. Normally, Dr. Ashwini and Dr. Sabyasachi, they join. Dr. Snehal, 3-4 of them normally join, but they are not here right now. So, Dr. Atul, any idea? Are they occupied or?
No, madam, I don't have any idea, but we can start the discussion.
We can start the discussion. It
Yeah,
was a
they
very
will be joining. I think they will be joining in 2-3 minutes.
Okay. I plan to do the role play first, but I think we can, reschedule and do it a little later. But just to start with, let me introduce the topic of the discussion. Today, we are going to discuss a very important type. I think one of the most important topics, I think, and that is disclosure of medical errors. I think most difficult, topic that we have to deal with, but that's part of the profession. So if I may ask you, what kind of errors have you noticed around you? Uh, Whether, doing patient harm or not, that's not a concern. What kind of errors have you noticed around you?
Can I start?
Sure, sir.
I have faced operating on wrong eye.
Mhm.
Once it was done by somebody else, and ultimately being the senior most in the organization, I had to face it.
Okay.
And
How did you manage and what was the outcome?
fortunately, patient was operated for cataract, and the other eye also had cataract.
Okay.
So, and luckily, the outcome of cataract surgery was good. So I confess that it was a mistake from the part of the team, but fortunately the eye that was operated, that was also necessary, and the lady has got good vision. Since the lady got good vision, nothing much happened afterwards.
So they have quietly, happily accepted whatever happened.
Yeah.
Any other situation where actually it did not concur with their expectation and then they were unhappy about it? Anybody else or Dr. Sil, whoever wants to share their?
There was one case where wrong IVL power was implanted in the eye. First post-op refraction, we saw there was a refractive surprise, and when we matched the IVL power, we saw the correct power was not given from the block room. Sisters give the IVLs to the patient, so there was a mistake at that point. So we counsel the patient that we need to do a second surgery and give you the proper power. The patient was not much agitated, but we had to confess that
there must have been a major discrepancy. That is why you had to go for the second surgery.
Sorry?
There must have been a major discrepancy, therefore you had to go for a second surgery.
Yeah. There was a big refractive error because of the wrong IVL power that had been put into the eye.
So the patient was operated, within few days?
In the first post-operative week only, the patient was operated and she got back normal vision.
That's so good.
The patient was not agitated, but it was a negligence.
Negligence, I know. I agree, yeah. Any experience, Dr. Atul, you would like to share from your hospital or from your personal?
Yeah, I have also got many experience like this, wrong IL power or wrong eye operated. But other than that, there was one experience when we could not put the lens. We had not told the patient earlier, and for some reason we could not put the lens, and so we had to disclose to them that we have not put the lens, and then we may need a surgery, second surgery again, and so that sort of. So this
So what
comes also in error only, na? This also comes
actually it's not an error. It's
error.
it's a part of surgical, complication. It's one of the possible complications.
But we hadn't told them initially. We hadn't given them any idea.
Patient perception about this is as an error. You're right.
Yeah.
If you look at it from the patient's perspective, they consider it as
then it's an error. Yeah.
And then somewhere also it also kind of puts a question mark on our.
Yeah, on our. Yes.
So we see it as a failure. That's another problem.
Yeah.
So we think I was not very efficient, or I was not very. I didn't do it well. That's why I could not do it. Yeah, that's how we also get overwhelmed with the situation. And then patient was okay. Was he or she operated?
Another issue I can remember.
Yeah. Yes, sir.
Another issue I can remember.
One second, Dr. Atul is completing.
We counseled the patient. They were slightly anxious, but we then explained them thoroughly, and then we did a surgery after 1 month again, and we put the lens, and then it was okay.
Okay. But for that time, they were quite apprehensive.
Yeah. For the first time, because it was a good lens. They had spent a good amount of they had spent some rupees for that, and so they were as anxious.
Naturally, yeah.
But there was no any severe reaction from them.
No strong agitation or something.
Yeah.
Yes, Dr. Sil, you were saying something.
Another case was because of bad handwriting of the doctors. The pharmacist dispensed atropine drop to the patient.
Oh, no.
And patient just rushed to the hospital because of blurring of vision.
But I'm sure that would have been held, that would have been, managed well by explaining that it's a temporary effect and nothing much.
Yeah. We did not want to hide anything. We just accepted it and said we are very sorry, but within 2 weeks' time you will be all right.
Thankfully. So any case where the result was irreversible or something that couldn't be undone. Any case anybody can remember? We have Dr. Varsha and Dr. Snehal also. I request them also to share their thoughts.
I had an experience in our hospital. The IL power was same. The lens was same, but instead of hydrophobic, we have put the hydrophilic lens. And somehow by sticker, the patient relative came to know that instead of hydrophobic, we have put the hydrophilic. And it was just a difference of 5,000 between the package of 2 ILs. And that reversing the surgery, like explanting the IL and putting another IL, has many adverse effects rather than putting it. It was just a matter of hydrophobic and philic. But patient my patient created so much havoc that he took us all the package compensation from us. It was under insurance. So it was a very bad experience for all of us.
But the patient was not informed after we realized, or it was the patient who noticed, or patient's family member who noticed?
No, patient noticed, ma'am. Actually, it was some runner's spot.
Okay.
That ball spot. We didn't get notice from the patient only. But we have, instead of hydrophobic, we have put the hydrophilic lens. And then reversing the surgery was a bit difficult for the patient also.
Yeah, I understand. But then nobody could counsel that, okay, this error has happened, but that does not change the outcome.
No. Yeah, everybody counsel. Patient wants to meet that surgeon only. So the surgeon also counsel her, but he was not ready to accept it, that ma'am. Was very angry.
So again, an incident that it's an evidence that sometimes, they put so much of pressure that just we think that by compensating them, we can get rid of them and we can, close the issue. But then that sets the wrong precedence also somewhere. they get
Yes.
to feel that, okay, we can, pressurize them and get the money back. That's true. So again, thank you for sharing your experiences. I think that was wonderful. Any other experience, Dr. Snehal, if you wish to share from your practice?
Ma'am, I don't have such an experience as such. Nothing major.
Okay, no problem. No problem. So actually, I wanted to do a role play, but I feel, I mean, should we do it with whoever is available, or Dr. Varsha, in how much time do you think you will be reaching home? I know you're driving. Dr. Varsha?
Sorry, ma'am.
Yeah,
Yes, ma'am.
Yeah, because I want to do the role play and I want everybody to be there to participate.
Yeah. So I will take around 20 to 25 minutes, ma'am, to reach home.
Okay. Because
Yeah.
Dr. Skill is also outside, and I want him to role play sitting at the station.
Yes, ma'am.
So and in any case, those who have their cameras on, they're already very seasoned in handling such situations. So I expected the pressures to do it so that we learn by doing it. So we'll just go ahead with the discussion, and I'll just share the presentation with all of you first, and then maybe if time permits, we can do the role play. So Dr. Abhilasha was supposed to make the presentation today, but she is not here. Any idea, Dr. Atul, if you could message her and check with her?
Okay, ma'am, I will just check with her.
Yeah, please.
I will just check. Yeah.
And meanwhile, I'll start the screen sharing and show you the presentation. Yeah. I hope you can see my screen.
Yes, ma'am.
Thank you.
Yes, ma'am, we are able to see.
Yeah. So as I said earlier also, probably this is one of the most difficult conversation to have, because neither we are prepared for it, nor we are trained. We don't even know what situation will turn into what outcome. But I think it's time that we discuss about how do we really deal with this situation when things go wrong. And at least we should have some idea. It could be you individually handling the situation. It could be your whole team handling the situation. But after all, I mean, you will have to strike conversation with the patient and patient party. And especially, I know we have a tendency to cover up things. We can't deny this fact. If we can cover up, we make all efforts to cover up. But then there are errors that cannot be covered. Also, there are situations when the patient party points out to the error and they are in know of what has happened. For example, we have number of cases where the patients have been operated on wrong side, wrong surgery, wrong medicine. And these are the things that cannot be covered. And that's the situation where we have to really deal with this situation, handle this situation. So today's discussion is all about when things go wrong, how do we really handle? See, we have a tendency that we normally say, like, for example, if I ask somebody, even in my relationship, in case if I fall ill, where will you take me? Suppose if I talk this in my family, the tendency is family members will say, "Aise mat bolo, please don't talk like this, please don't talk like." We think that by not talking about it, we can actually evade the situation, but which is not true. Whatever has to happen will happen. If you are in the know of it, if you know how to deal with it, if you have some idea how you have to manage it, or what are the do's and don'ts, what will work, what will not work. Of course, each one of us will have to handle that situation by being in the situation and mindfully analyzing what is the right way of dealing with it. But then we all know at least some understanding will help us in navigating the situation. So today's discussion, although all of you are very senior, very experienced, we have already dealt with such situation, will add to your understanding that there are some do's and don'ts that we have to keep in mind. And then also the complete hitch about not disclosing. And then what is the benefit of disclosure and what are the barriers of discussion will at least bring up some food for thought for all of us to contemplate and think how to be prepared for this situation or how to handle this situation. So if you were, in a flight which was in a near miss crash and some passengers, including you, were slightly injured, what would you like to know and from whom? What do you say? You can unmute and speak because we are just you can unmute and speak. Yes, Dr. Sil, do you wish to answer first?
Yeah, first we would like to ask the air hostess, and would be most interested to know from the pilot. The first thing, whether we are safe now, and the next thing is what actually happened.
I think, Dr. Sil, you have pointed out to a very important aspect of communication. You said, first, I would like to know from air hostess. So in our case, our air hostesses are our staff member, which includes our nurses, our optometrists, our cleaning staff, our support staff. So that means it's not just that we need to be prepared to handle this situation. Even our staff should know what they are supposed to speak or what they are not supposed to speak, or how they are supposed to reply to the questions and queries of the staff or patients or their family members. So I think that's one point that you have brought up, which was not in part of the discussion, but then definitely you have pointed out that even the first person will not be pilot with whom you will go and ask. It is the air hostess or air steward who would tell you, or you will expect them to know. Then of course, if chance given, you would like to know from the pilot, and once you land, and then you would want some briefing, from somebody senior who tells you what exactly happened and how it was managed. Dr. Atul, what do you think about it? What do you say about the same situation? Any additional thought other than what Dr. Sil has mentioned?
But the flight is about to crash.
Yeah, you had a near miss. No, not about to crash.
No, a near miss. It was a near miss.
Near miss, yeah. I mean, thankfully, we are all saved and we landed.
Yeah. That's what I wanted to know, because if it was going to crash, there was no thought, just to protect ourselves.
That's a good question.
What would you like to know? Same thing, madam. Why did it happen? What was was it turbulence? Or after we have landed, I would like to know why the reasons for the near miss crash.
What exactly happened? We want to know. We want to know truthfully.
Yeah.
Even if they say it was a weather, bad weather.
Turbulence. Yeah.
Bad weather or whatever. So, or we lost control, or we lost contact with the our air navigation. So whatever it is, we want to know the truth. That's one thing, and we want to know as early as possible. And also, like again, Dr. Atul, you pointed to a very interesting aspect of. There are a lot of near misses even in healthcare, where actual harm hasn't happened. It would have happened. Problem is, we don't acknowledge, we don't report. So when we don't acknowledge and when we don't report, those errors keep happening. And then we don't do kappa. So if you don't add a quality checkpoint to prevent that error from happening, you have not taken a corrective action and you are not going to prevent it in future. So near misses are more in number than the actual incident. But which near miss will convert into a actual incident, you never know. So that means every near miss has to be taken with equally seriousness. So that if this would have happened, how this would have damaged the patient's health, affected the patient's health, and what we can do so that it doesn't happen again. And usually patients' concerns are if they get to know कि ये हमारे साथ हुआ, चलो हम तो बच गए. But how will you ensure that it doesn't happen again? And this is a very common concern you will hear from the patient party. If you'll ask them, what do you want in this situation? तो वो कहेंगे कि डॉक्टर साहब चलो हम तो बच गए इस बात से. But then how will you make sure that it doesn't happen again? So I think near miss is also a very important aspect. So 2 good points that I've learned from this discussion is one, that the first person who will be actually responding to the crisis call is not the pilot, it is the air hostess. So we have to prepare our hostesses and hosts to be equally equipped with the communication skills to handle the situation in a very mature manner. Suppose if there's a patient in the OT and unfortunately due to any drug reaction, the patient has gone into cardiorespiratory arrest, and the family can see there's a lot of running in and out of the OT, and we are trying to do something, and they get worried and they ask, what is happening? Why is there so much of chaos? And why is everything all right? Because every patient's attendant waiting outside will be worrying. So, and they will not come and ask the doctor who is attending the patient. It's usually the nurses, it is usually the OT staff, it is usually the technicians who will be going in and out, carrying the machine inside. So they need to know how to respond in a very mature manner to such questions so that it doesn't add fuel to the situation. And then of course, as you said, near miss means it's also an equally important incident, and it should be taken very, very seriously. Thank you for pointing out. Dr. Sil, anything you wish to add? Dr. Mrs. Sil, anything you wish to add?
Yeah, I would like to ask the experience of the pilot. Experience, whether he was operating, operating, or he was being assisted by some trainee.
So again, now thank you for bringing that up. Now you would like to know pilots' experience in terms of number of experience or experience in that situation?
Number of years of experience.
Now again, what a beautiful question you have said. If my patient wants to know how experienced I am, how many surgeries I have done, how comfortable will you be as a surgeon to answer this question? And how valid you will think this question is? How sensible is this question? Why I'm bringing this up is there is going to be a time when patients are going to ask us these questions. If this question has come to your mind, this question will come to your patient's mind also. Especially they're getting evolved, they're getting educated, they're paying for this service. I'm sure in a more evolved society, these questions are already there. And probably that's upsetting us more now when we are asked these questions and we don't feel comfortable being asked about our credibility. Do you agree with me, Dr. Mrs. Sil?
Yeah, this is there, but they don't ask the doctor. They ask the counselors.
Yeah,
who do the counseling, do the booking. Yeah. So there they ask what is the credential of the doctor, how much experience. I want to get operated by the most experienced doctor and all those things. So for that, we need to have a good database. So counselors can be very confident saying that, no, this doctor whom I am giving you this, your case, he or she is very skilled. This is his data. This is his. So yeah, data will speak.
Wonderful, wonderful. So that means some homework already done will help us deal with that question also, whether asked before the surgery or even after the surgery. This can be asked after the surgery also. You're right. If something has happened And when you are breaking the news to the patient about some error, they may ask, who was the operating doctor? How experienced was he? So if we have that data ready, and if the patient counselor can say confidently that he or she is a very experienced doctor, and they operate almost like 20, 30 cases every day. So it's not that they lacked experience, but it happens in some cases where this kind of situation occur or can go wrong. Any question from Snehal and Varsha? Or any thoughts that you wish to share?
Hello, no, ma'am.
Yeah.
Hello, ma'am. Yeah, I want to add something.
Yeah, please.
Actually, definitely, I would like to know what was the reason for the near crash, and if it is not like means if it is beyond the pilot's this thing, then means if it is a climate or something like that which we can't avoid in that situation. In fact, I would like to appreciate pilot that thank God it was just a near crash. It is not landed in the crash.
Yeah. And you will also, appreciate the confidence and courage and experience of the pilot to have navigated through that situation.
Definitely.
I believe that this pilot was very experienced and management. So that means communication and your expertise in your work both add to ultimately creating that confidence in the patient's mind about your ability to deal with that situation. And again, like Dr. Mrs. Sil said, patient doesn't ask the doctor. They normally ask the counselors. So that means our counselors have to be thorough with their homework. They should know it well that I can be asked this question and I should be very confidently able to handle these questions, not giving false assurance, but at the same time, with the help of some data, confidently handle that question so that they are satisfied. So I think this situation has given us a lot of food for thought, and it's a good analogy to carry home that if this is what we expect from our flight attendants and from the pilots, then definitely our patients also expect something very similar to this. I wanted to do a role play, but we'll wait for it and let's see if we can do it later. This was the situation I thought that there's a patient who, came to you for pterygium surgery, and your staff mistook him for another patient because he was the same name person and posted that patient for cataract surgery. Now you have operated the patient, and after the surgery, there's a realization that, okay, this patient was not for cataract, but for pterygium. And now you have to inform the family of the error. But we'll see if we can do this role play, and after a while. So I'll just skip some of these questions and we will come back to these questions when we, do the role play. Give me a second. Okay. So I think if I may ask, those of you who have done this already, what is a common feeling when you have to do it, or even you're asked to do this responsibility of disclosing the error to the patient's family? Dr. Atul, if I may ask you, what is the common inner feeling or thought process?
Feeling of guilt.
Feeling of guilt.
Embarrassment, you can say. You have written already there.
Yeah, embarrassment. Yeah. Like very rightly you said that case where because of some complication we could not implant the
lens.
Yes. Yeah. Especially if you have painted a very optimistic picture or a rosy picture. Because I've seen sometimes people saying, "अरे LASIK surgery तो OPD procedure है, क्या दिक्कत है ना? फेको तो 2 मिनट का काम है, तो बहुत ही अच्छा procedure हो गया. So there is no possibility of." At that moment, we forget that there is some percentage of risk involved in every situation. अब LASIK surgery जब हम करते हैं और बाद में जब पेशेंट को डिप्लोपिया या ग्लेयर या और कुछ challenges आते हैं, then we really cut a very, very sorry figure in that. Any other feeling, Dr. Atul, that you can think of? What do others say? I've written 3 primary feelings. I think one is embarrassment. Second is we fear the aggressive reaction, and then we fear the risk of litigation, that I can be in trouble because of this. Any other feeling beyond this? Dr. Sil, you wish to say something?
Yeah, it's a personal dissatisfaction mostly.
Oh.
That I could not fulfill my responsibility.
Oh. So maybe we attach too much to the outcome. That is what I say when I talk about emotional detachment. When I say emotional detachment, that is what I wish to point out. If you have done your job with great responsibility, like when it comes to pre-assessment, when it comes to counseling, when it comes to doing the procedure, if you have followed the protocol throughout, even then if there is some complication or there is some outcome that is not anticipated, we have to consciously, mindfully learn to detach from the outcome. Because like you said, personal dissatisfaction. Yes, I'm not saying be complacent, that okay, I don't care for the outcome, but getting emotionally affected can be very burdening. So we have to mindfully learn not to burden ourselves with the outcome, but learn from it. What can I do in future to prevent such errors? Thank you for bringing that up, Dr. Singh. Any other point, Dr. Varsha, Dr. Snehal, Dr. Mrs. Sil, if you wish to add to the discussion? Anything that you think that comes as a thought or a feeling in a clinician's mind?
Same, ma'am, same.
Same, nothing different. Okay. Yeah. Dr. Sil, anything you wish to say?
No, same.
Same. Okay. Actually, it's a very difficult communication. I've been saying right from the beginning, it makes anybody uncomfortable, even very seasoned doctors, when they have to do it at least minutes before that, there's increased apprehension, there's increased concern. What will be the outcome? Will the patient family agree with me? Will they understand my point of view? Will they blame me for the outcome? Will they hold me responsible for the error? So a lot of thoughts go and come. They come like flash of ideas, and then there's always the fear. Suppose if they catch hold of me, especially if you can see they are more in number and they are they are very aggressive in their appearance and their body language and in their communication, then it becomes all the more distressing and uncomfortable for the person. So if I may tell you, actually medical errors happen quite a lot. According to this report by JCI, medical errors are third commonest cause of death in US. We haven't done any study in our country. If we did, I don't know where we will stand. So we can't consider that medical errors are very, very, negligible. Only thing is very few errors are reported, and very few errors are very huge in terms of their impact, especially in ophthalmology. I think majorly it is the wrong site operated, or maybe the surgery didn't go well, the IOL couldn't be put, or there was a vitreous hemorrhage. But then, of course, whenever there is an unanticipated outcome, it is very distressing to disclose that. This is another, a report by Professor Ashish Jha, who is in Harvard University and who did this estimation for our country. He says around 5.2 million errors happen annually in India. I would say it's an underquoted number. There must be much more than that. But I think the learning that I would have from it is that almost 18% of the errors are around surgery or the procedure. So that means it's quite a huge change. Almost 1/5 of the errors are around surgery. So ophthalmology is also part of the surgical listing. But a lot of errors happen even around medication. That warns us that when we are talking about medicine, we need to be more careful and very clear in terms of explanation to the patient. And then, of course, almost 30-35% of errors happen in patient care. Incidentally, most of the errors are result of poor communication. Wherever we fail to communicate either verbally or in written, illegible handwriting or unclear message or assumption, they all come in the error, and then we make mistakes in patient care. Now, if I may ask you, what is the definition of error? What is a medical error? Because Dr. Atul, just now, like you said, that we failed to put the lens, and we are considering it as an error. Patient perception is true. They take it as an error because they didn't get what they expected. But is it actually legally an error? I think that clarity will give us a lot of confidence that it is not an error. It is something else. So what is medical error? I'm not asking for definition, but what is your understanding? I'm trying to just understand that.
A breach in the normal course of the planned surgery or thing.
Yeah. So that means any protocol that needs to be followed, and if we fail to follow the protocol, then it's a medical error. Any other understanding from others, from Varsha, from Snehal, Dr. Mr. and Mrs. Singh?
It's a deviation from standard accepted norm unknowingly.
Or knowingly also sometimes?
Yeah, sometimes knowingly.
So a lot of time we know that we are taking a bigger chance than we should be taking. But then that turns out to be a medical error. So it's a failure to complete an action as intended or use of a wrong plan to achieve an aim. It may or may not result in adverse outcome. Incidentally, we think if it has not had any adverse outcome, then it's not an error. But if we go by the legal document, anything that has gone wrong in terms of our actions, it's a part of medical error. What is, I can see some message in the chat box. Give me a second. Okay, fine. Okay, unanticipated outcome. What is unanticipated outcome? So this is what Dr. Atul was saying, when the result is significantly different from what was anticipated. So for us, we don't have to feel that it's an error from our side, but the patient will definitely view this as an error. And then what is omission?
Part of the procedure was completely not done.
Absolutely. So something that was left undone, or it was neglect of duty, then it's an omission or outbreak. That is also part of the medical error. Can I request others to keep their cameras on? Why I'm saying, because as it is, we are very few in number. Dr. Mr. Sil, I think I'm okay if you keep your camera off because you are at the station, but then can I request all others? Because I can't see whether you are there or not. Dr. Vilash, I forgot that you are there. I didn't ask you a question because it slipped out of my mind that you're around. So I request you to be comfortable, but have your camera on. So you can see this is the clarity between the medical error, unanticipated outcome, and omission. But patient will view everything as an error. So if I go for the definition from the patient's point of view, they have a very broad definition. Anything that did not bring their desired result is an error in care. Whereas our definition of error is very narrow, where actually there is a deviation from the accepted standard of care, then we say it's an error. From patient's point of view, even non-preventable events are also part of the error, like post-operative complication or surgical complication. That's there, but for them, that's also, an error. Poor service quality and poor communication also is considered as part of the error, which we normally don't consider. Especially in surgical branches, we think if I've done my surgery well, everything has gone well. But from their point of view, all that is part of error. Now, coming to the extent of disclosure, studies suggest that patients want all errors that cause harm, even near misses. They want to know because there is a curiosity, there's a desire to know what was about to happen, what harm would have happened to the patient. Whereas from our side, we want to only communicate the errors that cause significant harm. So we believe there's no need to communicate the errors or near misses which has not harmed the patient. Talking about the how should the disclosure of an error happen? Patients prefer truthfully, compassionately, and complete explanation, whereas we prefer to do it in a more objective manner with minimal disclosure. We want to just give very little information, that also in a very matter-of-fact manner, not in a very elaborate manner, and not from the patient's perspective, but we just want to do it so that we say that we have explained to the patient in whatever way that's possible. Now, another important question, that's about apology. Patients expect that we should apologize for the error. How many of you actually think that yes, we should apologize? You can raise your hand, just say, we should apologize. But normally, I think we are not comfortable doing it. Are we? Are we comfortable doing it? No. No. And also we want to say we are sorry, but we feel hesitant to say that. Because we think if we say sorry, then there's a possibility that, I may have a legal, problem. So therefore, we don't want to, apologize and accept that I'm responsible for what has happened. When to have the conversation? Patients want immediately. They want as soon as possible, we should know. So when we took up that case of near miss air crash, so if I asked you, when do you want to have the information, you said immediately I would like to know from the aerostase. Or when we land, we want the pilot to explain us what exactly happened. Similarly, patients want as early as possible. Whereas we think that when we have all the facts, and rather we think if we can delay it, because delaying we think will calm them down or maybe give us more time to become comfortable with the fact. So we are not very prompt in doing so. Now, if I may ask you, what do patients expect? What do patients expect?
Patients always expect a good outcome.
But when it is a disclosure of medical error, what do patients expect?
They expect that the truth will be disclosed to them.
True incident should be disclosed to them. Okay, that's right. What do others say? What more patients want?
They expect all the things are to be explained clearly, and they need to know the outcome. So what will happen next?
Okay, so they want to know everything clearly, and then also what is going to be done now. What is
done
going to
now? Yeah.
What do others say? Dr. Mrs. Sale, Dr. Vilasha, Dr. What do others say? Dr. Snehal?
I think patients always wants to know whether it will, what would be the impact, whether it's long term or is there any way to correct it? That means, is it reversible or irreversible damage has happened?
Absolutely. So they want to know the implication of the error to their health, whether it is reversible, irreversible, how is that going to impact their life? Correct. Any other thought, Dr. Mrs. Seal, anything that you think the patients expect?
Many times they ask whether they will get the refund of the money.
That's one of the questions sometimes they expect, that since you didn't deliver me what I needed, so you have to return the money. And that becomes a bone of contention because we are not okay with this idea, because we have done our job and we haven't done any error. I mean, we think we haven't gone wrong. We did our best, but then we don't want to do that. So I think we have covered most of the points. Like patients expect the statement that error occurred. First thing they want from us is that we accept that yes, error actually happened. They want to know the details, what happened. They desire full disclosure of harmful errors. They don't, and especially anywhere if you will appear to be hiding any information, that itself is going to be a very big problem for them, because they feel that we are not being honest with them. Of course, they want to know the implication to their health. Is it reversible? Is it irreversible? How is it going to affect my quality of life? And what am I going to do in case if it doesn't, recover or it doesn't go well? They also want to know why it happened, because why will give them the idea about with the seriousness that we, had while doing the. So if you say, in spite of all the care, this thing happened. Also, sometimes they want to know who is responsible for it, whose mistake it is. So how would you handle that? Would you like to tell who is responsible for it? Suppose you are senior most in that situation. Like, for example, even if you take that role play situation where your staff, mistook the patient's name and then, put it for the cataract surgery. Now, will you say it was my staff who did it? Will you tell that it was my nurse who did it? Will you say it was my OT technician who did it? Will you?
No, ma'am, I don't think so. It's a good idea. We can take a responsibility as a team.
Yes, I think it's always a good idea not to, point or any one person, because then that person can be targeted. That is one thing. And second thing is, even if my nurse has put the patient for surgery, as a surgeon, it's our responsibility to ensure, if you go by the surgical safety checklist, it says that you have to match the patient's name with the patient's identity, and actually rather check with the patient's name so that you don't make any error. So it's not a good idea to put it on one person's thing. A lot of time I see conflict between surgeons and anesthetists, who will do the breaking, who will do the disclosure of error or breaking of bad news, because a lot of time I've seen they will ask the anesthetist to go and talk about it. So I mean, we really need to think about it, that whose responsibility it is. And then patients also want to know how will the reoccurrence be prevented. They would like to know what are we going to do, to avoid something like this from happening. So when it comes to the disclosure gap, very honestly, 90% of the doctors support the principle of disclosure. If I asked you, all of you said, yes, I think we should disclose. But in reality, only 1/3 of the doctors actually do the disclosure. So most of us, focus on how can we cover up the error and how can we prevent the leakage of information to the patient and the family. Studies clearly suggest that 3/4 or 2/3 of the errors are not reported. So almost 60-70% of the errors are not reported, and they are brushed under the carpet. Even if the disclosure happens, it never meets the patient's expectation. We do it just for the heck of doing it, but we don't do it in a very clear and open and honest manner, especially because we know that we have not been trained to do it. Most of us haven't done the right way of doing it. So we do the way we think is the right way, and we just try to, finish off with the responsibility. Now, if I may ask you, what are the barriers to disclosure? Why do we hesitate disclosing? What is the reason?
Patient might take a legal action.
Yes, there's a fear of legal action. Absolutely. I think that is one of the major reasons. What else?
Shyness.
Sorry?
Guilt.
There's a guilt. So, guilt or fear?
Fear.
Guilt is fear. Yeah. There's a fear that there will be a repercussion. There will be there will be some retribution. What do others say?
Reputation at stake.
Yes, reputation at stake. We fear that people will not consider me as a good surgeon or a good doctor. Absolutely, absolutely. What else?
Somewhere in our mind, we think that this is not going to change the outcome of clinical condition. This
Absolutely.
might be an excuse or something, but we always think it is not going to change the clinical scenario. So, what is the
So
point
why?
of
So
creating?
why tell?
Yeah.
So why tell? Also, in case if I mean the patient is not affected adversely, we think there is no need to inform. What else? Dr. Snehal, Dr. Varsha, what other barriers can you think of?
Patient will demand monetary compensation.
Yes, that's another thing. We fear that we will have to either, compensate the patient, maybe do this the whole thing free, or maybe even pay, compensate the patient. Absolutely, there is a fear. So most of the, I think, factors we have covered. For example, we are also skeptical about the benefit and believe that disclosure is unnecessary, especially if the patient has not been harmed. We think there's no need to do it. We also feel that it will unnecessarily distress the patient and family. So there's no need to tell them. Let us manage in the best possible manner and then say this is what it is, but not tell the truth to the patient. Also, especially when the patient is unlikely to find out. The patient can find out, then you have to share all the information. But if the patient is not in a position to find out, then definitely we think that we can do away with it. Very rightly said by some of you, there's a fear of retribution from patient and colleagues. They will look down upon me. They will not consider me a good doctor or a good surgeon, or they may defame me. They may talk ill about me. They may go and give poor reviews on social media. So there's a fear that there'll be retribution from patients and colleagues. Of course, very rightly said by Mrs. Sil that there's a fear of legal action. And Dr. Atulya said financial compensation that the patient might ask for. Also, there's a fear of difficulty handling patients' emotions. We feel that, okay, when I talk about it, they can get angry, they can become aggressive, they can start fighting or hitting or breaking things. So we feel that I can't handle all that. So we say, let's avoid that and avoid that situation. Also, some of us think that disclosure of medical error is a factual conversation, and it's not a complex interpersonal conversation. So even when we do it not in the right manner. I'll show you two videos, very beautiful videos, again done by Indian doctors, that will show you how we normally do it and what is the right way of doing. And there's a lot of food for thought from that videos. I'll be showing it after the presentation. So a lot of us do it in more like a matter of fact manner. Okay, I just need to tell you that this is what has happened in your case. Not realizing that how it is going to completely change the patient's life or the family's, life about it. And then again, many of us, believe that outcome is not related to action on part of the person disclosing. So I'm not responsible for it. That's not my responsibility. And then this lack of training, which I've been pointing out from the beginning. I don't think, has anyone had any training in how do you go about doing it? Or any discussion on this earlier? No. But we are all doing it. We know we are doing it from our own understanding. So since we don't have the training, so we are not very confident. We don't know what is right way of doing it. So only if we are forced to do it, we do it. Now, if I may ask you, what are the benefits of disclosure? How do you think it will benefit if we disclose honestly to the patient?
Ma'am, I want to ask one question about previous slide. in case of point number 1, is it really necessary to disclose?
Dr. Snehal, if you go by the book, it's patient's legal rights to know. That's one thing. So if you're hiding information, you're taking a chance. Patient can sue you. Patient can take you to court that you did not disclose information. Second thing is, in reality, if you hide, and especially if it's something that's, that's vital and patient should know, patient will ultimately get to know. One, a lot of time your own staff member go and tell. In a number of places we have seen where the OT technician or any other general duty staff will go and talk to the patient's family and tell them that this is what happened in your case. Or patient may go for second opinion. So what happens if you have not been honest to the patient, you have not told, and they get to know, they feel cheated and then they want to do harm. Then they become revengeful. So of course, disclosure or not disclosure completely becomes your choice, especially if the patient does not know and is unlikely to know. But I'm going to share with you a couple of studies where they have implemented full disclosure of, a full disclosure policy and how they have been benefited. Again, I'm not saying that you have to apply it as it is in your system or in your own way of functioning, but being open to the idea, and if the need be, you need to disclose how you should do and what you should keep in mind, at least give us little confidence in dealing with the issue. So if I may ask all of you, what are the benefits of disclosure?
In long run, it helps in developing trust between the patient and the doctor, and all the professional colleagues other than the doctor knows that complications and errors are bound to happen, and this doctor had been honest in disclosing this thing, and that actually builds the image of the doctor.
Very good. Absolutely. Actually, that's very true. We normally think that my image in the eyes of others will go down. It will go down if you are repeatedly making errors because of carelessness. Then, of course, anybody will say that you are not a very responsible doctor. But generally, that's not the story. Generally, from every mistake, we learn and we correct ourselves and we make ourselves better. And that really builds your image in the eyes of your patients and your colleague. And overall, having an image of a very responsible doctor, very, nice relationship and nice atmosphere, even that goes in our favor. You'll be surprised to know that evidence suggests that skillful conversation and follow-up can actually reduce the risk of litigation. A study by Harvard said that only 3 to 5% of the patients injured will actually sue the doctor for the negligence if you communicate to the patient and their family member in a manner that they understand your point of view. Patients normally don't sue us for negligence. They sue because they have not been given proper communication. Also, if they can sense lack of empathy and feeling of being mistreated. Post-operatively, if you are not empathetic, if you are not treating them in the right manner, then they can be hurtful and they can be revengeful. And also, anywhere if they can sense that you are withholding the essential information. Like, for example, they say, आप हमें summary बना के दे दीजिए, हम कहीं और दिखाना चाहते हैं. And then you try to evade that. They can see that you are not cooperating. So in such cases, they are more likely to, sue the hospital or the doctor. So the problem was not negligence. It was mainly because if you are not communicating and handling the situation, effectively in a more responsible manner. So this is one of the many studies that I came across when I tried to understand how full disclosure policy has helped. University of Michigan applied, full disclosure policy in 2002. So they did a comparative study to see how has this helped them. And you can see that one data was collected in August 2001, and then the second data was collected in 2005. That means 3 years after the full disclosure policy was implemented. The annual litigation cost almost reduced to 1/3. Also, the average time to resolve the cases also became almost 50%, from 20 months to almost like 10 months. Number of claims also reduced to less than half, almost 40%. So this is a evidence that if you, again, we have a different culture, we have a different setup. I'm not saying that we follow it and we apply, but at least we need to be more open to the idea where we are honest and transparent to the patient. I think that would bring down at least the violence and aggressive reactions that we receive from the patient. So I'm going to share you a couple of guidelines on how do you go about disclosing the error. I have picked them from the Canadian Patient Safety, recommendation, and also the UK's National Patient Safety Agency. You can design your own guidelines. They're just like suggestions, advice, but you can always design your own, protocol in your system. But there has to be a way of doing it. I think that's the clarity I want all of us to have. Now, as usual, I think the first step is preparation, because you are going to deal with intense emotions. You are going to have a very difficult conversation. So you really need to prepare yourself. Check in. Am I comfortable? Can I do it? Am I feeling confident? What is it I'm feeling from inside? So that will give you an idea. I can do it. I can manage it. I know I can handle it. I'm good at it. So that self-check-in regularly is very important. If you think you are not very comfortable, not confident, don't go into it. Seek assistance. It could be your colleagues, it could be your seniors, it could be your team, whoever it is, but then don't do it alone, because it's not easy, as I said, and it takes time to learn how to go about handling it. It's always good to pair up with someone. When you have two people, then you can manage the situation effectively. Before you actually start any kind of discussion, go through all the details, thoroughly before you start talking to the patient, because they are bound to ask you some cross questions, something that can, upset you. If you don't have that information at that moment, you will not appear confident, and also they will lose confidence. Oh, aapko pata hi nahi hai case ke bare mein aap kya baat kar rahe hain. So that means very important it is to know all the facts, what exactly happened, what was done, why it was done, what was the basis for whatever decision you took on the spot, and whatever it is. So review all those things, have those things handy. Prepare yourself from strong emotions. You're going to experience emotions from within yourself, and definitely the patient or the family will have, their own set of reaction, emotional reaction. Coming to performance, again, rather than, beating around the bush, it's always good to state very honestly that there has been an error. Because if we try to beat around the bush and not come to the point, they will not listen to you. They'll say, "Pehle ye bataiye galti hui thi ki nahi hui? Pehle ye bataiye hua tha ya nahi hua tha?" So there is no harm stating that there has been an error. Describe the course of events, what exactly happened, how things progressed, where what went wrong, but do it in a very simple and non-technical language. Use frequent pauses to give them a chance to ask questions, to clarify. Because if you are just speaking, it will look more like a monologue. Make it a dialogue so that they can ask questions, they can react, they can respond. So use frequent pauses in between. And then also state the nature of mistake, what consequences that mistake will happen, and what corrective actions you have taken to minimize the damage. So you have to really, it will be kind of more like a dialogue where they'll be asking you a lot of questions in between, but you have to be as transparent, as honest as possible. Apologize. I think we have discussed about it. We all know that we think apology would give them an upper hand. But honestly, expressing personal regret and apology calms them down. They are disarmed, actually, very honestly. And then if you take their attention to patients' welfare, what best you can do or they can do to make sure that we minimize the damage, that would help. We have talked about apology earlier also, that it has two meanings. One is there is expression of compassion that we have to constantly use. And then there's expression of responsibility that yes, we have done this. This is our. Sometimes we make statements, they do not sound like apologies, but they look like excuses. I would say avoid that. If there was an error, then I would have admitted, or there was a mistake, but it doesn't change the outcome, or the mistake certainly did not change the outcome. दूसरी आंख का भी करना ही था ऑपरेशन भैया, तो चलो हमने वो भी कर दिया है. Especially with dentist, I normally laugh and say कि भैया एक बारी हमने सुन करा था, एक दांत निकालना था, दूसरे में भी कीड़ा लगा था, वो भी निकाल दिया, तो आपका फायदा हो गया, आपको 2 सुई नहीं लेनी पड़ी. But of course, that's not the right way of apologizing. And sometimes these things happen, but they are not done willfully. So these apologies do not actually make much of sense. I think it's important to take responsibility. So I think I agree, I accept. That's very important. Do not blame or speculate them, or don't blame them. आपकी गलती है, आपने क्यों नहीं बताया कि उनको शुगर थी, आपने क्यों नहीं बताया कि उनको ये था. That's not going to help in this situation. And don't accept the fault unnecessary. If you haven't done anything which is wrong, you don't have to take that responsibility. Invite them for, invite questions, ask them if they have any questions, ask their concerns. आपका क्या concern है इसको लेकर, आप क्या सोच रहे हैं, आपको क्या लगता है. So when you ask these questions, one, you get to know what they are thinking. Second, you are able to give them answers so that satisfies them. And then also, you get a chance to read their mind. How are they absorbing the news? So you will get an idea when you will invite questions and try to answer them. Then once you have answered their questions, please make a follow-up plan. They may want to go and see the patient. If you can immediately allow, you can allow them, or you can say, let's first settle the patient and then we'll let you know, we will let you in. Giving your contact details, I don't know how comfortable you will be, but it doesn't matter. If they want, they can get your contact details from anywhere. But that would build their confidence when you say, okay, you have my number, in case if there's something that you need to discuss, you can call me, or this is my room where I am available, you can come back to me, we can, or maybe in the evening also, I will update you about what is the situation, depending upon whatever the situation is. The whole idea is that you kind of tell them what you're going to do now and how you're going to minimize the damage. Also, what they need to do in case if you have to refer the patient to another hospital. So maybe if you say that, okay, we will do this, but then we don't have this facility and we need to, send the patient to another hospital. And I'll tie up with them, I'll speak to them, I'll inform them. But you need to go and, complete the formality. So whatever the plan is that you have to discuss with them. And also, if they want to contact you, please remain accessible. I think this is very important. If you are not available after the procedure, after the surgery, they don't take it as though you are busy or you were genuinely occupied. They will take it as though you are avoiding them. So that's going to fuel the situation. So I have personally experienced a couple of cases where the patient was operated for a simple case like appendicectomy. When the patient was to be operated, it's a very huge hospital in Delhi I'm talking about. I'll not name the hospital. So when the patient was to be operated, they called actually from home to check if there's a room and there's a possibility of surgery. So this family kept receiving phone calls from the patient coordinators and from the reception that yes, the surgeon is available, the bed is available, you can come at this time, these are the OPD time. So they were given a very VVIP welcome when they went for the surgery. Now after the surgery, unfortunately, this patient developed fistula. And trust me, not even once the surgeon who had operated the patient, met the patient or talked to the patient. It was only the residents and other doctors, who did the dressing and nobody even explained that this much time it will take to, for the fistula to close, or what is the next line of treatment. Patient had to come for almost like 1 month for dressing. Not even once the surgeon met the patient. So patients actually feel cheated. And you can see the difference in the treatment. When the patient needed surgery, patient was welcome. Patient received number of phone calls from the hospital, everybody calling, "Ajo, ajo, ajo, ajo." And now once the patient is operated, patient is needing some explanation, at least some consolation, or some understanding that why this fistula has happened and what is going to be done. The doctor was not available. So I think this is one point I always say, that don't hesitate meeting your patient, or at least talking to them on phone and making them comfortable. So once you have discussed everything, once you have, made a follow-up plan, explanation, everything, it's time to document. Very important, because that's going to create evidence of whatever you have done. And you will immediately remember also all the details. So it's always good to document as early as possible. Document the incident, document whatever actions you took, rationale for your clinical decision, whatever clinical decision you did, to do the surgery, to not do the surgery, to do the second surgery, and what was the rationale for that. Document that. That's going to save you, that's going to help you in future. Then clinical outcome and further plan. Even documenting this will create an evidence that you did your work in a very meticulous manner. Of course, whatever discussion you held with the patient and family, whatever their questions were, and who was there, the name and the relationship, whether son, daughter, wife, husband, whoever, write their name, write their relationship, questions they asked, what answers you gave them. If you can just, note down all those things on this document, that will, give them an idea that this is what was discussed. Of course, I didn't write here, but we have to also write your details in case if you need to be contacted. When your contact details are. So that document will first of all work in your favor to note down everything so that you don't miss any important point. If you were asked about this, say 1 year after this, you will not remember whatever you did or whatever you said to the family or whatever you discussed with the family. But if you have made a document, then I've written everything. Plus, also in the court of law, this document will definitely save you in case if we have any challenge later. After every such incident, I always say sit and reflect, because that's something that's going to help us improve our performance. Sit back and self-check in. How did I feel? How did I do? What could have I done better? What was my inner thought process, feelings? What could have I done before the procedure to prevent such errors? There's no harm discussing with your colleagues. Everybody is sailing through the same situation. All of us are facing similar situation. Discuss with them, take their opinion, ask them how they deal with it. That will give you a lot of insight in different ways you can manage difficult situation. Read material to update. We have a lot of information available on Google. Read articles, read guidelines that are available. Attend programs to learn crisis management, because these are all things that can be learned, practiced, and you can do it actually. So this is in a nutshell about the protocol of disclosure of medical error. And to summarize, I think just 8 points: prepare yourselves, state what exactly happened, apologize, take responsibility, invite questions, make follow plan together with the patient's family so that they feel that now they are part and parcel of the treatment and follow. Document and then reflect. At the institutional level, I think we need to bring a cultural change. It's not just at an individual level, because disclosure policy at an institutional level should become a part and parcel of the communication. So integrate disclosure, patient safety, and risk management activities. More you will talk about it, more people will come forward and share their even near misses. Because I think the culture that we have to create is where we don't punish the mistake. We actually start working on how to prevent this from happening again. So establish a disclosure support system. We always talk about the victim, the person who has suffered. We need to talk about the second victim, because the clinician who is going through, or the person who has done the mistake, is the second victim of the situation, and they require equal support. So provide background disclosure education to all your team members, to your nurses, to your optometrists, to your OT staff, because they are the one who will be communicating much before you. And time to time, continue training and sensitizing people. Provide emotional support to your healthcare workers. Also create a culture of patient safety and a culture of employee safety. Actually, we need to create a culture where people report errors promptly without fearing the repercussions. So you can imagine the kind of cultural change that you will have, where people will not hesitate admitting that, yes, this happened. And then, of course, once you have implemented something like this, it's important to also check the improvement of, what, whatever disclosure they are doing, how well they are doing. So this is in a nutshell about disclosure of medical error. I have two videos to show you. First of all, any questions about what we have discussed? What are the thoughts, by the way, after the session, after the discussion? Is it looking like doable thing? Yes, Dr. Vilash.
Can you hear me?
I can hear you.
So just a thought to share with you, madam, that when you were discussing the actual fear while disclosing the medical error, or that is very thoughtful. Like if you had asked me within a second to reply instantly, I would have given my first defense mechanism as answers. But through your slides and your explanation, I realized you have thought through this. And behind each emotion, there is a hidden another emotion. The way you said, there is always a fear of that if I disclose, there is always apprehension that we might have to face litigations or something. So I realized that, yeah, this helps a lot to introspect. That these are the true emotions that being a service provider we face, but we might not dig deeper and superficially we are thinking. So thank you for that.
Thank you. The whole idea is that, see, by closing our eyes to the reality, we can't run away from the reality. And if that's my fear, I need to address my fear. I need to see that my fear does not affect my performance. Because ultimately this fear is going to affect your performance in the long run. And if I accept it, what worse will happen? If it has to happen, it will happen. I believe it in this way. And if I've done my job well, then at least I'm sure I can prove myself that I haven't done any mistake willfully. And then, of course, there will be a situation, whether you like it or not, you have to handle that situation. So at least some clarity on this will definitely help us. Thank you for that input. Thank you. Any other question? Any thoughts? Did you find this discussion useful, meaningful? Was it ever earlier discussed in this structured manner?
No, ma'am.
I think that's the whole purpose of this program, that at least we address these issues in a structured manner. Now, in case if you'll have to train your junior residents about how to handle disclosure of medical error, you will know, okay, this is how we can tell them that in case if we have to do, we have to do. This is one of the occupational, you can say, hazards or occupational responsibilities, part of the occupation. It's a dirty job, but then I have to do it. So 2 videos that I want to share with you. Of course, there is not error. Like Dr. Atul, you said very rightly, even when there is not error, but there's a complication, we fear that patient is not going to differentiate between the two. If the outcome is not as expected, patient is going to be, annoyed and angry and unhappy with us. So these 2, I mean, I really like the videos, and this again done by Indian doctors, and I really applaud them for the effort they have made in doing these videos. In the first video, you will see how we normally do it. And this time when you watch the videos, I want you to observe the body language, words, paralanguage, that is tone of voice and the way he conducted himself and the way he did. So try to observe the mistakes, I would say, because from that we have to learn. These are the things we don't have to do. And then I'll share with you the second video, how he could have done it differently. Let me share the videos with you. I hope the video is visible to all of you. Thank you.
Yes, ma'am.
Thank you.
Who's with Mrs. Kumar? I'm Mr. Kumar. Yes, hello. I remember meeting you earlier in the OPD. This is Mr. Girish, my brother-in-law. Hello. Please sit down. There are a few things I'd like to discuss with you about the operation. I'm afraid I have some bad news. We ran into some complications early into the surgery and we've had to shift Mrs. Kumar into the ICU. What happened? What complication? Oh no, is she going to be all right? Well, she lost a lot of blood during the surgery and we couldn't realize where the bleeding was coming from. So we've had to open her up and it took us some time to find where she was bleeding from. In the meantime, her blood pressure was low and we've had to give her a lot of blood. Finally, we managed to control the bleeding. This was supposed to be a simple, routine operation. How can this happen? Well, Mr. Kumar, you remember the 1% bleeding complication risk that we spoke about? Unfortunately, Mrs. Kumar has had bleeding. We're doing everything we can to help her. We're giving her blood and IV fluids to support her. So now we have given her bleeding space. She's going to be okay, right? Well, she's lost a lot of blood and her blood pressure was low. So we don't know how long she'll take to recover. We'll just have to wait and see, watch how she does. What do you mean? Well, we just have to wait and see how she does. She's going to be okay, right? When can we see her? The ICU doctors are working hard to stabilize her. At the moment, she's not stable, so you can't see her, but we'll let you know. When she's stable, you'll be allowed to see her. I don't understand. This is supposed to be a simple procedure.
Can I request everyone to come in? So what do you think was not appropriate in this video? What are the things that?
There was little lack of empathy.
Not little, lot of lack of empathy.
Those facts were written in a systemic manner, but yeah, lack of empathy, maybe not in that premises in front of other patients where patient relative can express their feelings. Maybe that was not the area.
Right. It was done in an open area. It was done in a waiting area. What do others say? Yeah. What do others say?
The body language was not good. At the end, when the patient party was trying to say something, he was just trying to escape.
He just walked off. And that's what normally we see. People don't like to, talk for very long. They just want to escape this situation, move away from that situation. Thank you for bringing that point. What do others say? Empathy was missing, very rightly said. He did not he did not even wait for the other person to complete, and he left the conversation in between. Third, very rightly said by you, it was done in an open area. It was done in a waiting area. So the family could not only family, even you will not be able to handle it effectively when you do it in an open area, because you are always conscious of the fact that there are people around you who are watching you and who are observing. What else was not okay?
He didn't allow the relatives to ask the question.
He did not allow. And didn't even ask do you have any questions? He did not allow. What else? When the family wanted to see, he said, he didn't give any exact way out that how they will be allowed and when they will be allowed. But in a very loose term, he said. One very fine observation that I want to bring to your knowledge is, whenever there are 2-3 relatives, it's very important to engage all of them. If we just speak to the primary caretaker, though we know she is the daughter or he is the son, but you will always see there will be 2-3 more people with the attendant. Make sure that you engage with all of them. What happens when you continue talking to only this prime person, the others feel neglected and ignored. They can go and instigate the patient's attendant in their own manner. But when you engage them, when you try to answer their questions, when you try to, make them feel important, they feel that, okay, our questions were answered. We were addressed. Another point that I want to bring here, you will always have somebody who will be nodding to what you are saying. That's a very important cue. That person will help you to handle this situation. Because when there will be a difference of opinion between the patient party, you can talk to that person and say that, see, I want patient's welfare. Probably the family is too overwhelmed to see the patient's welfare as the primary focus of our attention. I would suggest that we should not lose time in doing other things. Let's just make sure that we do the best for the patient's interest. That can also help you to avoid aggressive reactions coming from the family, because then they will go and talk on your behalf and say that he did his best or she did her best. Let's not think of damaging them, but rather think of our patient. Any other thought from the video? He seemed to be in a hurry, no? He seemed to be in a hurry. Okay, let's watch the second video. could he have done it in this manner?
Who's with Mrs. Kumar? I'm Mr. Kumar. Hello, I'm Dr. John. I had met you earlier in the OPD. I don't believe I've met you. I'm Girish, his brother-in-law. Hi, Girish. I'm Dr. John. There are a few things that I would like to discuss with you about the surgery, but I would prefer that we do the discussion in a more private place. Is that okay with you? Okay. Please come. Unfortunately, I have some bad news to share. We've run into some complications into the surgery and we've had to shift Mrs. Kumar to the ICU. What happened? What complications? Oh no, is she going to be all right? I understand that this is not news that you expected to hear, and I'm very sorry about this. There is a lot of information that we have to share with you, and please feel free to stop me if I'm going too fast or if you need any clarifications. Now, Mrs. Kumar had some bleeding early on in the procedure, and we did not exactly find out where the bleeding was coming from. That's the reason we had to open her up, and it took us a long time to find where she was bleeding from. In the meantime, she lost a lot of blood and her blood pressure was low. And eventually, we did manage to find the blood bleeding point, and then we thought we have to shift her to the ICU to monitor her blood pressure. But this was supposed to be a simple operation. How could this happen? Well, in order to do this operation, we first have to put a needle into the abdomen to grow gas before we put the camera in. When I put the camera in, all I could see was blood. I could not see where the bleeding was coming from. And that's the reason I decided to open her up. Where did that blood come from? The bleeding was coming from a major artery inside the abdomen, and it appears that the initial needle insertion was responsible for the bleeding. Who put that needle? I put the needle in, and I'm very, very sorry about it. Just was not expected. We are trying our best to minimize the effects of the bleeding. Is she going to be okay? I wish I could tell you, but it's too early. I just don't know. I certainly hope so. She is on life support medications right now, life support systems for breathing. She is getting blood to keep her blood pressure up and powerful medications to keep her blood pressure up. We're doing all we can. When can we see her? Well, the ICU doctors are working hard to stabilize her, and as soon as she's stable, we could see her. I will let you know. Do you have any questions for me? Really don't know what to say here. I can understand that. If there are any questions, please don't hesitate to ask. In the meantime, I'm going back to the ICU. I will keep you updated on her status. Is that okay?
Again, I would not say you have to do exactly like this. It's your situation. You need to decide how you want to put it, how you want to put it. I'm sure many of you will be skeptical about the idea of accepting that I put the needle and because of this, the patient had bleeding. But we all know that it's a documented complication because needle insertion is a blind procedure and it is one of the possible complications. When you insert needle to blow the oxygen or the air. So the whole idea is it's not about analyzing the video. Let's focus more on the language part, the body language part, empathy, attitude, connecting with the patient and their other family members. I think the idea of this video is to learn from that. It's important to talk to them and become comfortable in handling their questions and explaining them in as simple manner as possible so that they can understand what exactly happened. That's the idea. So any thoughts about this video? I really appreciate the role done by these doctors because it's not easy to even act on the camera. It's not easy. So I really appreciate their effort to have done this video for all of our benefits. And we are all benefited by it. Any questions about the topic before we move further, because we have to have 2 presentations today.
I like the way they included the question, like who put the needle, and very responsibly and said that unfortunately I was the one who put the needle and I'm very sorry for that. I think that is the very, very tricky part. As you said, we cannot blame it on others. Even our juniors, trainees are doing it. We beat a mistake of a staff. Ultimately, you have to take a responsibility. And I think that what was a more calm approach. You take maybe more calmly, patient will accept.
Absolutely. And throughout, if you're able to maintain your composure, they understand that you haven't done anything willfully or you were not careless in handling the situation. But then that's one of the risks in any procedure. That's the whole idea. So if there are no more questions, I think we can start with the presentation. We have 2 presenters today, Dr. Atul and Dr. Ashwini. So I'm sorry, Dr. Abhilasha, I'm sorry. Yeah. Are you ready, Dr. Abhilasha? Yes or no? Unmute your
first.
Sorry?
I was asking Dr. Atul if he wants to present first.
Yeah. Dr. Atul.
Yeah, I will present first.
Yeah. So I'm allowing you to share your screen, Dr. Atul.
Yeah.
You can.
Okay. So today I will be speaking on handling difficult or bad audience. But first, before that, let's do a little activity. We are well versed with role plays now. So I need a volunteer who would like to speak maybe 1 or 2 minutes on any subject, recent or whatever. Can I get some volunteer? Can I request all to switch on their cameras, please? Dr. Abhilasha?
What I didn't get the scenario.
You can speak up the whatever you subject you want, your pediatric department or whatever, just for 1 or 2 minutes.
But about the experience, like bad experience, you want
No,
to say?
just speak about your department, whatever you want to speak. Okay. So I will give you some 30-40 seconds to think about it. I will keep you in the waiting room. Okay. And then I will again switch you on. Then you can speak. Okay. So I will be putting you on the waiting room now. Madam, can you please put her in the waiting room?
Yeah, I think I'll put in the waiting room. Yes, I've sent.
She's in the waiting room now?
Yes.
Okay. Yes. So rest of us, now we have to be the bad audience. Okay. So I want someone while whenever she will be speaking, I want someone to ask questions regularly, the interrupter ones. Someone should be talking. Someone should be the electronic enthusiast, always mobile. They should be speaking on the phone. So Varsha, what you will do?
Dr. Atul, I think one bad audience we can show to be, we all switch off our cameras.
Yeah, switching off cameras also.
And let her not see anybody. And then
so whenever she starts, we can switch off the cameras, then we can switch on again. Then afterwards, someone can interrupt her. The arguer, who wants to argue? Varsha, you will do that.
Yes. I will
anything, whatever, argue that this is not accepted. Okay. And Dr. Snehal, you can just switch on your mobile and talk loudly on the phone while she's speaking. Snehal, are you there?
Yes, sir, I'm there, but I'm not in my house right now. I'm just traveling somewhere.
Okay.
He's at a very beautiful place. I can see a very green background behind her.
I'm at my mom's place, actually.
Oh, that's so good.
Okay,
Have your camera on. Let's see.
Dr. Mrs. Subrasil, can I request you to just speak on the phone? Can you just speak on with your phone while Abhilasha is talking?
Okay.
Yeah. So
also, Dr. Snehal can talk to her child. She has a baby.
Yes. That
yes,
was I was
the chatterers. Yeah,
yes.
Snehal, you
Keep
can talk with
yourself
your
on
child.
mute, Snehal.
So one by one, we will disturb her.
Yeah, this
We
form
will
also is a good
Okay.
idea.
All right. Yeah.
So who will be the first? We'll switch off the our videos.
We call her.
Then
We call her.
you
We can do anything at random.
Okay, we can do randomly also.
Yeah, I admit her.
Okay. So you can let her in, madam. Abhilasha?
Yeah, I've admitted Dr. Abhilasha. Yeah, she's there. Yeah.
Abhilasha, are you there? Abhilasha?
Can you hear me, sir?
Yeah. You can start talking. Yeah.
So I would like to share a recent experience in my OPD that I saw a 9-year-old girl.
Dr. Abhilasha.
Yes.
Excuse me. Yes, where is your OPD?
I work at HV Desai Eye Hospital in Mohammad Wadi area of the Hadapsar.
Okay.
Hello.
Okay, fine.
Hello. Can you hear me? Hello.
Okay. You carry on, Abhilasha. Yes.
हॅलो
Yeah,
हा
thank
ते
you.
आपण उद्या करू नंतर करू आपण काम ते हो येस नंतर करू आपण हो नंतर
Yes, we can't
So
hear you,
that-
Abhilasha. Yes.
I request the audience to mute themselves so that we can carry the discussion, and whenever anybody wants to interrupt and ask questions, I'm happy to take the.
Hey, Shrisha. Hello. Hi, baby. Where are we going?
I again request all the audience.
You come this side. What are
Hey,
you doing? What are you
Shrisha.
trying to do?
Hi, baby.
Hello.
Hey, Abhilasha, you can mute them on your side.
Hello. Okay. Acha.
Again, I request the audience to mute themselves.
Hi, how are you, Srisha? Hey,
Dr. Abhilasha, we cannot hear you.
What are you doing?
Dr. Atul, I'll be
Abhilasha, please continue. We are eager to listen you about your OPD.
Okay, then now I think
You had a taste of bad audience.
one more factor. I'm going to ask people to put their videos and cameras on also, and so when I was in the waiting room, I realized, okay, what is this topic, and now.
So I think each one of us should have a taste of this audience so that they know.
So now you can understand how can the bad audience affect the speaker. So today I will be talking on how to handle these situations. So you can see my screen?
Yes.
Yeah. So I have a small video also showing bad audience, types of bad audience. So these are the chatterers who keep on speaking while the speaker is going on. These are some of the interrupters who eat during the discussion. They open the candy bars. They make noises of all the candy bars and everything. These are the mobile enthusiastic people who you can see always pick up the mobile and they are doing something on the mobile. And these are some of the people who keep on clapping in the middle of the performance. So they will clap, unnecessary clapping. So these are some of the types of bad audience. Okay. So now, what is a bad audience? A bad audience can be defined as a group of people. Just 1 minute. Yeah. A bad audience can be defined as a group of people who are unresponsive, disengaged, or actively disruptive during a presentation or speech. Common traits of a bad audience include lack of interest in the topic, personal biases or prejudices, poor communication skills, and negative attitude towards the speaker. A bad audience can affect the speaker's presentation by making it more difficult to engage the audience, increasing anxiety and stress levels, and potentially damaging the speaker's credibility. So I have broadly classified the bad audience into these types of people. Some people are the talkative ones, some are the interrupters, some are the chatterers. There are some silent people also, and the electronic enthusiastic people. So how to deal with these people? I will be afterwards I will be displaying those. So we can again differentiate the bad audience in the degrees also. So what are the low degrees? So some people will be daydreaming, their body language will be negative, they won't be participating, cell phone use. Some people enter late or leave early. In online programs, keeping the camera off mode. Moderate degree will be verbal indication of distrust, disagreement, conspicuous attention to other work, sidebar conversations, chronic cryptic or sarcastic comments. The high degree will be display of aggressive behavior, dramatic exit from training venue, threat made towards other, disparaging remarks towards others. So now how do we deal with such audiences? Okay, so one by one, the talkative, we can recognize his contribution and then assert that others must have a chance to talk. We can target the question to other participants by name. Avoid making eye contact with the talker after asking a question. Look to another section of the room instead. When the talker pauses, immediately thank him and call on other participants to comment. The interrupter or the arguer, so for him, we have to write an outline on a whiteboard showing the order of topics to be covered. Assure the audience that you will address their comments and questions at the end of the session, and so they should not disturb in the middle. Keep the participants engaged by interactive learning activities. Ask the interrupter to complete a specific task such as recording other participants' responses so that he will be busy. Acknowledge the arguer and thank him for contributing. Ask the arguer to explain the reason for the comment, find merit in one of his comments, and then move on. The chatterers. We often find these kind of people. So invite the chatterer to share his topic of conversation with the group. We can stop talking and look at the chatterer till he is quiet. Restate the point being discussed and ask the chatterer for an opinion. The silent people. Ask them a question you are confident they can answer easily. Ask a question to the group, suggesting to take turns while answering, and don't start with the silent ones. Respond with positive enthusiasm when they contribute. The electronic device enthusiastic. We have to set clear ground rules at the beginning of the presentation, set solid strategies to engage them. Sometimes we have to just ignore and move on. We cannot do anything else. Coming to the do's and don'ts. Do research your audience beforehand. That is very important to understand their interests, needs, and concerns, and set ground rules at the beginning. Do tailor your presentation to your audience to ensure that it is engaging and relevant to them, and stick to the time. This is also very important. Do anticipate objections and prepare counter arguments in advance. Do remain calm and composed even if the audience is being difficult. Acknowledge the audience concerns and questions and respond thoughtfully. Do redirect the conversations if it is going off topic or becoming unproductive. Maintain control over the presentation and the audience to ensure that your message is effectively communicated. Be assertive but respectful when dealing with disruptive behavior. Show some empathy, listen carefully, and search for a grain of truth. Don'ts. Don't take a confrontational or defensive approach to a difficult audience. Don't ignore the audience concerns or questions, even if they are challenging. Don't get sidetracked by off-topic discussions or unproductive debates. Don't lose your composure or become defensive, even if the audience is being rude or disruptive. Don't take criticism personally. This is very important. Don't take criticism personally or let it affect your confidence. Don't engage in arguments or heated discussion with the audience. Don't let the audience take control of the presentation or the conversations. Don't forget to maintain a professional demeanor and tone throughout the presentation. So, in conclusion, handling a bad audience requires presentation, composure, and assertiveness. By researching the audience, anticipating objections, and maintaining control over the presentations, speakers can effectively communicate their message and engage their audience. Thank you.
Thank you, Dr. Atul, for a wonderful presentation, interesting activity. Dr. Abhilasha, I'm sure, was shocked. But I think you guessed afterwards, no?
So that is the thinking I did in wedding area. Okay, why to talk about my random experience?
Everybody did everything. Everybody started using phone. Everybody started.
Everybody switched off their camera. I was like, okay, that's quite rude.
So I wanted to give taste to everyone of when you have your audience camera off.
This activity was actually suggested by Madam herself.
Okay.
Yeah.
So it created empathy, I think, in most of us.
Yes.
Okay. So I think now, if any questions to Dr. Atul about the presentation? Okay. Then let's have Dr. Abhilasha's presentation. Go ahead, please.
So I'll share my screen.
Yes, I think you can.
Can you see my presentation?
No. I think you have to start sharing first. Screen share.
Okay.
Yes, now we can see that you're starting to share.
So we'll go for slideshow.
But it has yet not started the sharing. It's saying that it has started, but we are not able to see your screen. It's something completely blank.
Give me a second. What happened to my... Okay, it says your screen share is loading.
Yeah, we can see it now.
Is it visible right now or not yet?
Yes.
Yeah, it's visible.
Yeah. Okay. So the topic is experience sharing to enhance the participation. So whatever I was going to discuss when Dr. Atul asked me to discuss, I'll share that first, my experience with all of you. That recently I saw one around 9-year-old girl in my last OPD. And since then, it's been like 4 days and I've shared this experience with my colleagues in an informal setup. So the girl was accompanied by her mother and father. And they were, let me come to the diagnosis. So the diagnosis was basically right eye cataract. That 9-year-old girl, her reflexes were also very slow. She was when I asked her to sit on the chair, she didn't do it quickly. So her reflexes were a little slow. Then I examined her, and then I asked parents, when read the notice that there is a white opacity in the right eye. So it seems they were not very much interested in sharing the truth, like they have already noticed it. Mother said 4 years back, and father was not interested in sharing that information. And he just said, we have been to other 2 hospitals, and they asked us to do the surgery. To show me the files or something. So previous file was 6 months ago. So I was very amused. Can you hear me?
Yeah, there was slight disturbance, but now we can hear you.
Yeah, okay. So I was amused to see that 6 months back only, quite a reputed ophthalmic surgeon has advised them cataract surgery, but it seems they did not bother to undergo the surgery. So I really was curious what was the exactly factor that they did not know, whether it was economic or anything else. So again, father was hesitant to share or discuss any information about that. So I skipped that part and I went ahead with discussion of what is the plan of action for right now. And they agreed for everything like surgery, all the investigations and the economic factor and everything, they agreed easily. And the moment I explained them, what will be the post-operative scenario, and I mentioned glasses, the father interrupted me saying that, "Nahi na madam, glasses, chashma to nahi chahiye." Then I realized what was the hitch in the whole story. That he said, "नहीं madam, चश्मा तो नहीं चाहिए मतलब operation के बाद कुछ तो ऐसा कीजिए जिससे चश्मा नहीं लगना चाहिए बच्चे को." So I was like taken aback by the fact that their child is not able to see, but the father is more worried about the cosmetic part of that child, who is just 9 years old. So I tried sharing with him that it's okay to have glasses post-operatively. But again and again, he was asking for the way we put in adult, the multifocals, can't we put same thing for the child? Again, he was saying कि लड़की है तो चश्मा नहीं लगना चाहिए. Then we share a couple of examples that nowadays everybody is wearing. Doctors amongst us are also wearing. So there is no taboo for glasses, but he was consistently reluctant on the very same factor. So, and he did not turn up for the next procedure also. So I'm still thinking about that experience. And I shared this experience with a couple of friends that have you come across with the similar situations where you have counseled the surgery, but patient has not converted into the actually opting for the surgery. So I would like to ask other colleagues, like there are like everybody else in this platform, to share if they have come across with such experience that they have counseled, they have done their best for the counseling, but for some reason patient has not opted for the surgery. Anybody from the yes.
Yeah, this is a very common scenario. After you counsel the patients, the pediatric cataracts, to undergo cataract surgery, they say that the child is too young. Cataract surgery is done for old people. Why should we get it done now? So then you have to talk about amblyopia and all those things. So, and we had one experience, the mother had congenital cataract, and that time she was not given proper block. So she had a very painful cataract surgery in both the eyes during her childhood. So when she brought her child, who was also suffering from congenital cataract, she was having that painful history in her mind, and she was thinking whether this child will also have that traumatic experience. So when we came to know about her experience, we said no, it will be done under general anesthesia. The child won't have any pain and all. Then she got convinced and got the child surgery done in both the eyes.
Wonderful. So this is how Dr. Shubha found out the way so that patient conversion will enhance. Ultimately, it's for the benefit of the patient only. I would like to ask other participants also, 1 or 2 participants, to share their experience, not just pediatric related, in any, like Dr. Snehal, Dr. Varsha, anybody. Anybody else? Okay, that's fine. So I would like to stress upon the fact that, so whenever I asked, let's share the experiences. So experience sharing is to not just enhance the participation, but it is a great powerful strategy to learn from others. So consider the same topic if management is holding, like why there are patients are getting counseled for the surgery. Suppose we have counseled 100 patients in a day for the surgery, only 25 patients has opted for the surgery. What is the reason? And let's arrange a meeting and we will tell you what to follow, like what protocol to follow, so that there will be a more conversion. So that becomes a dictatic kind of thing, like somebody from the authority is sharing their protocol so that your conversion rate will enhance. Instead of that, the experience sharing definitely enhances the participation. So instead of somebody, a senior person coming on the stage and giving you the guidelines how to counsel in a better way and how to convert patients from to opt for the surgery in a better way, it's always great for the instructors to be a facilitator so that people will start sharing. So it's a powerful social learning strategy. Discussions takes place within a social learning platform in a lot of ways, through discussion boards, live charts, virtual classrooms, and so on. So in all these conditions, instructors are like facilitated to make sure that discussions are relevant. So it's a very famous saying by Louis C.K., if anybody is fond of his TV series, that when you have used up all the basic ideas, then only you can dig deeper. So when we are done with same worksheets and PowerPoint and funny pictures or any other activity, then you will start thinking about what else can be refreshing, or how can I enhance the participation of the audience, and how can I be more relevant to the audience. So utilizing experiences for social learning is a very tried and tested way of learning. It aligns with the natural preferred way that most learners choose to learn, and it doesn't so without forcing for the learning. So where can be used? It can be used to discuss accomplishments, discuss what not to do in a particular scenarios, discuss lessons learned, or discuss your dilemmas or where you are stuck at, so that other people can contribute to find out the solutions. Advantages of sharing the experience to enhance the participation is it is more relevant, it is more meaningful, more enjoyable, and more informal way, because there is no such thing called as a structured way that you have to fill under the headings. People like to share freely, and because they like to they share freely, it brings out more raw experience. And you can experience whatever that person has experienced in a more raw and realistic way. This helps fellow learners take inspiration from their successes as well as from their mistakes. As I said, this doesn't need any background study or formal preparation in the form of PowerPoint or some slides and everything. People are more inclined to share the experiences and learn in this manner. What could be the disadvantage of this technique? That if there is a large audience, take-home message might get misunderstood by the audience, or it is a little time-consuming. Because there is no structured way, topic of discussion might get deviated or off topic, and you cannot analyze the effects afterwards. Because what will you put exactly? Because there is no heading and it's a free speech, it's open-ended, and it becomes little difficult, but it is very helpful to achieve your goal. What are the do's? Ask people to share experiences if they want and don't make it mandatory. As Dr. Atul said, don't start with the silent audience, and whenever that silent part of the audience is sharing their experiences, just applaud their experiences or just appreciate their behavior. It has to be relevant and precise as well. What are the don'ts? Not to intrude someone's personal space or information, not to force someone to share any experience, or don't make it mandatory. And I think that's it. That's what I wanted to say. Thank you.
Can you please stop sharing the screen?
And that I hope my
Thank you. Thank you for your wonderful presentation. Any questions to Dr. Abhilasha? I think honestly, experience sharing, I also enjoy the most, because you get to know so many new perspectives when you ask questions to your audience and you ask them to share their experience. And if you're able to make them comfortable and talk about concerns, I think we get a lot of new learning from each other. That's a very good topic, and we should use it, especially with the adult audience. They enjoy talking about their experience because they have some emotions attached to it, and that gets expressed when they share their experience. It's a wonderful way of learning. Thank you for the presentation, Dr. Abhilasha. Thank you. And we have a lot of other experiences also. I think good audience, bad audience, all that also you got to experience in your session. Thank you. So if we have no more questions about the session or about the presentation, I'm sharing the feedback form. I request you to kindly give your feedback, and then we close the session. And we are just left with one more session that we are meeting on Monday. And we are going to talk about a patient counselors program that is being done in both the hospitals, and how you can use these skills in your patient handling. Dr. Shubhra actually attended a lot of discussion when I did it at NNN. And she was almost like part and parcel of the whole discussion. But I'm sure doctors from HP Desai also will benefit from the discussion. We'll have a discussion around the patient counseling skills and how you can use that in your patient counseling in the next session. And that's the last session. If you have any questions, you can ask me in that session. So I've shared the feedback form. I request everyone to give their feedback. have received 5 responses, waiting for others to complete so that we can close this session.
Thank you, ma'am. I'm leaving.
Thank you.
Thank you, madam. I will also have to leave.
Thank you so much. Yeah, I understand it's late evening, so you can all take your leave.
Okay. Thank you, ma'am. Thank you.
Thank you. Dr. Varsha, I think you are still to give your feedback.
At the end of session, I think role play is the most powerful tool to experience.
Yes, to be in that place, it's very
totally convincing.
And it actually transfers, message very quickly. You don't have to speak a lot, but most of your thoughts get automatically transferred. Yeah.
Totally agree.
You have to actually make, use of different pedagogies. I think that's what is my learning. And it keeps the audience interested. Otherwise, to hold a session for 2.5 hours, it's not, very easy. So I think I've received all the responses. I've received 6 responses. Yeah. Okay, ji. Thank you so much, everyone. Let's meet on Monday for the last session.
Thank you, ma'am.
Thank you so much. God bless you.